welcome to Science Friday.
Here are some for E as well. The one on the top here is one of the ways that you can define E.
What makes a field more likely to have an unbalanced gender distribution?
So this can be like, in the case of this paper, gyrification or brain folds.
A neuroscientist started to look at the brain as
like the
more as an interconnected
incredibly negative consequences.
Not what How much time do I have?
15-20 minutes.
All right, cool. So I'm Alice, and today I'm going to be presenting on how treatments for depression can change your brain. Should I? All right, so I'm going to be presenting on how treatments for depression can change your brain. So firstly, a disclaimer, if you couldn't tell from the title of this, we're going to be talking about depression today, so if that's a sensitive topic for you, then feel free to step out at any time during this presentation. Come back to Science Friday another week. Secondly, the research in this paper, it's only a small slice of everything that people have researched in depression, so don't take it as a diagnosis. We recommend that you consult with your medical health care provider if you have any questions or concerns with your mental health. Yeah. So now I'm going to talk about what led me to the paper. Firstly is the prevalent topic of depression and the rise of depression. I'm sure you've seen many like TikToks and articles and videos about how people are getting depression like more now, especially in this generation. I found two papers. Firstly, in 2016, there was 9% of people who were reporting to have experienced symptoms of depression. And then in 2020, the NIH reports 17% of adolescents experiencing symptoms of depression. So that's almost double the percentage. And we know that depression levels are rising even now, so it may be even more than 17%. That's like 1 in 5 people almost. Secondly, I've experienced a few symptoms of depression, especially during the pandemic, and they're not very fun. There's a lot of consequences to declining mental health rates. You experience changes in mood and tiredness in sleep, so not very fun. And thirdly, my psychology class, which led me to a few papers surrounding like the hippocampus and depression and how they're correlated, and that's what eventually led me to this paper, which is treatment-specific hippocampal subfield volume changes with antidepressant medication and cognitive behavioral therapy, specifically in treatment-naive depression. So if we're going to unpack this title a little bit, it's going to be, the hippocampal, it's a part of your brain. And the researchers here are wondering what is the role of the hippocampus in the treatment of depression, specifically for antidepressant medication and talk therapy, also known as cognitive behavioral therapy. Yeah. So as for the context and the background of this paper, there have been other studies that have studied depression in the hippocampus, but never treatment of depression in the hippocampus. So in previous papers, they've seen a link between depression and hippocampus atrophy, which is just shrinkage in the brain, or shrinkage in the hippocampus. So the hypothesis that this paper came up with was that talk therapy and or antidepressants would increase the size of hippocampus. And so the purpose of this paper was to investigate the difference in hippocampus volume changes for two things. Firstly, for those who did respond to the depression treatment plan and those who didn't respond to the depression treatment plan. And their second aim was to see the difference in hippocampus volume changes between those who recovered from depression, but specifically with medication and talk therapy. Oh, also, this is the hippocampus. It has an important role in learning and memory, and it has been shown in other studies that for neurological and psychiatric disorders like major depressive disorder, the hippocampus can be affected. So onto the methods of this paper, how they carried out this experiment. There were 172 treatment-naive patients with major depressive disorder. So this means that these patients were never before treated with depression. And the other thing is major depressive disorder, it's done by an official diagnosis And you have to achieve a certain set of criteria based on the ISD or the DSM, which are both depression level tests in the psychiatrics field. So 45 of these participants were treated with talk therapy, and then 127 of them were treated with medication. And then this treatment plan lasted for a total of 12 weeks. And the tools they used to measure the hippocampal volumes were the MRI scan free surface 6.0. You can see an example of what it would look like on the right here. These are like the hippocampus images. And what they use to measure depression levels is the HDRS-17 test, which is the Interpreting Depression Rating Scale, and it tests participants on 17 different symptoms that they self-report based on like their personal emotions and thoughts. Question? Do I know what type of antidepressant was used? Good question. So they used 2 different types of antidepressant medications, but I wasn't able to find them in the study. But the reason why they chose 2 different ones was so that it wouldn't like necessarily impact the results. Okay. Yes.
For the patients using antidepressants, were they also in therapy or no?
Oh no. There were 2 different groups, one only talk therapy and one only medication. The question was, for the patients taking medication, were they also on a talk therapy treatment plan or not? And the answer is no, they were in separate groups. Okay. So now we're going to move on to the graphs and results of the study. The first one, the researchers wanted to see the difference in hippocampal volumes between non-responders and remitters. Non-responders being the participants who did not recover from depression according to the HDRS test, and remitters, those who recovered from depression according to the test. And on the y-axis is the hippocampus volume. The non-responders are the graphs in yellow, and the remitters are the graphs in red. BL stands for baseline, which is their hippocampal volumes before the 12 weeks of treatment, and week 12 is after the 12 weeks of treatment. And what you'll see here in the left hippocampal tail is that for those who recovered from depression, their hippocampus volume stabilized, and for those who did not recover from depression according to the test, hippocampal atrophy can be seen, like here. Okay. Yes?
What's the significance of the left hippocampal tail?
What's the significance of the left hippocampal tail? They actually measured the entire hippocampus, but this is just one of the graphs that they showed, probably because it has like the most significant difference between those who responded to treatment and those who didn't. Okay. And then next the researchers wanted to see the difference between those who were remitted, but specifically those who were treated with medication and those who were treated with talk therapy. So this is the hippocampus volumes for those who were treated with medication and talk therapy who were remitted from depression. Again, the y-axis is the hippocampal volumes, and those who are treated with cognitive behavioral therapy, talk therapy, the graphs are in green, and those who are treated with medication, the graphs are in blue. And across baseline again, BL is before the 12 weeks of treatment, week 12 is after the 12 weeks of treatment. So across all 3 graphs here, you'll see similar trends within these 3 hippocampal subfields, which is that for those who are treated with cognitive behavioral therapy, you can see hippocampal atrophy. And for those who are treated with medication, you'll see that their hippocampus volumes is stabilized. Yes?
The y-axis is percent of normalized volume. Do you know like what the comparison is to?
Yes. So the study actually had a formula to test percent normalized volume, which is the y-axis. Essentially, it was the total hippocampal volume divided by like total cranial volume times 100, and then that's how they got the y-axis. But essentially, they're just measuring the hippocampus volumes.
It's a fraction of the total brain volume of every single patient and every single test subject. Like, is it like an average brain volume, or per person, if they were measuring this test subject and they had a greater overall brain volume, then that might change the result versus the second person who has the same size hippocampus but just takes up less space relative to the rest of their brain. Does that make sense?
Yeah, I would like.
As in, was it the change of their brain from before the treatment, or like just of like their brain?
Like from patient to patient, did they look at the percent volume of the individual patient's brain, or did they have an average brain volume that they calculated for everyone? And
Okay, I would assume that all of the graphs show each individual patient's hippocampus volumes and the dots that are connected here are the means and the averages of the hippocampus volume. Yes?
I don't think I quite understand the connection between is hippocampus size being used as a proxy for response to treatment, or why do we care about the size of the hippocampus as opposed to whether they respond to treatment?
Oh yeah. Okay, so I mentioned this earlier, but so they're measuring two things. First is the depression levels of the patients, and secondly is the hippocampus volumes. And in previous studies, it's been shown that there seems to be a correlation between the hippocampus size and depression. So this study was wondering, because the hippocampus seems to be affected by neurological disorders such as depression, would there be effect on the hippocampus volume based on treatment of depression and the depression levels? Okay, cool. Next, the reason why the researchers theorized there was a difference between hippocampus volumes, even within those who recovered from depression, they theorized it was because psychotherapy or talk therapy, it involves functions such as appraisal, shifting the way that you think about events and shifting your perceptions, and it's thought to take place in the prefrontal cortex of the brain. Whereas for medications, they work chemically in the limbic system and in the body, and that may affect the hippocampus. So it shows that even when your hippocampus is not increasing in size necessarily, you can still recover from depression. And yes.
So just to clarify, this slide is saying that psychotherapy specifically targeting parts of the brain you're just resulting is happening?
Yes, this slide specifically is saying that psychotherapy is working on different pathways than medication may be. So that's why researchers thought that there was a difference in hippocampus volume changes. And the reason why medication was theorized to work and directly affect the hippocampus is something called neurogenesis, or the neurogenic hypothesis, which suggests that depression is at least partially caused by an impairment of the brain's ability to create new neurons. And this process, the creation of new neurons, it's called neurogenesis, which in other papers it's been shown to have a correlation between antidepressant medication and neurogenesis. So yeah, when the hippocampus is affected by depression and when there's an impairment in the brain's ability to create new neurons, then researchers thought that because antidepressants stimulate neurogenesis, then perhaps this is the reason why antidepressant medications work. But this does not mean that depression is caused by a lack of neurogenesis. It just shows that antidepressant medication is just one effective treatment method for depression. And I have index cards for this, but. Oh, one other thing I wanted to talk about for medication is that there's other unintended or even unwanted side effects of medication. So even though antidepressant medication may be treating depression levels, there may be other effects such as tiredness, mood, insomnia, and et cetera. So there is a cost-benefit analysis that you need to know about. Okay, yeah. So now onto the conclusions of this paper. The first one, we've already talked, oh no, we didn't. Okay, so antidepressant and medications, both groups have equal rates for treating major depressive disorder. So in both groups, there were equal rates of treating depression levels. So So that relates to the second point, which is that the hippocampus does not have to increase in order for depression symptoms to decrease necessarily, because this is especially true, you can see in the people who are treated with cognitive behavioral therapy. And thirdly, the reason why antidepressant medications may work is because, or antidepressants may protect against hippocampus atrophy and may help in depression levels is because of neurogenesis, creating new neurons in the hippocampus. And there were a few limitations in this paper that I noted. Firstly, there were non-equivalent sample sizes. So for those who were treated with talk therapy, there was only 45 participants, and those who were treated with medication, there was 127, and the paper doesn't state why, but it's there. 45 people to be treated with talk therapy is a relatively small sample size, so that's something to take into account.
Can I ask a question about that point?
Yes.
Were they, I'm assuming they also weren't randomized into the two treatment groups since the group sizes were unequal?
The paper didn't mention, okay, the question was if the sample size, if the participants were randomized into different groups. The paper doesn't mention as to how each participant was sorted into each group, whether it was medication or talk therapy, if like they chose it or if the researchers assigned it to them. So we don't know that. I'm not sure why.
It seemed like there was that one graph showing the CBT group had higher volumes at baseline, so my guess is that there must be a non-randomization thing going on.
Okay. The second thing is due to the heterogeneous nature of depression, meaning that there are multiple causes and origins for one to get depression and multiple ways for a person to be treated from depression, there were confounding variables. So here, everyone in this study, they were sorted into one group, which is major depressive disorder patients, and then they were given either talk therapy or medication, and we don't know if the patients got into depression because of like levels of stress or genetics or something else. So further research would be needed to see if depression levels can be treated according to like the causes rather than just the symptoms of depression. Thirdly, 12 weeks is a very, very short time frame to measure hippocampus volume changes specifically for non-pharmaceutical interventions like therapy. And other studies that have studied brain volume changes or just brain changes for patients with non-pharmaceutical interventions, these studies took place over like months and years. One example I can think of is this one study was measuring like the gray matter changes in the brain within taxi drivers, and that study took over the place of years. So 12 weeks is a very, very short time frame, and that's why, so even though we didn't see any changes within the brain from patients who are treated with talk therapy, it doesn't mean that talk therapy doesn't necessarily impact the hippocampus volumes. It might just need a longer time frame, and it would be interesting to see a study that took over the place of like maybe 6 months or even more. Fourthly, the standardization of treatment, like what exactly is a dose of cognitive behavioral therapy? What exactly is a dose of medication? This paper doesn't specify like if they were taking doses daily or weekly, specifically for therapy, because there's many different types of ways to go into talk therapy. It can be on a daily basis, it can be on a weekly basis, it can be for an hour, less, more. We don't know what exactly they're measuring and like what exact dosages they're using for participants. And fifthly, and sixth, there are a few ethical concerns with this paper where we're not sure if informed consent was given, or like informed consent is just tricky for those major depressive disorder, as it is a serious mental disorder and that can potentially impact decision-making abilities. And also, we're not sure if the non-responders, those who didn't respond to the treatment plan, if they were offered a chance to take the other type of treatment, because both antidepressant medication and talk therapy have been shown to be effective treatment methods for treating depression. So usually it's a common practice for papers, for studies like these regarding treatment plans and mental disorders to offer the other type of treatment, because then it optimizes the chance for the patients to recover. Yeah, so questions that I had and things to study in the, oh, yes?
What about taking both treatments like at the same time? What are the possibilities of that? Would that be better or would that just interfere with?
Or you're a genius, okay. So,
Oh, sorry, I noticed it was on the slide, but.
what Aura asked is, what about a combination of therapy and medication? And that is one thing that I had in mind on the second question. But firstly, what is it about antidepressants that make people's lived experiences with depression different? What is it about antidepressant medication that makes the hippocampus effect changed? And is it really because of the neurogenic hypothesis? Because before, people theorized that antidepressants worked because of the serotonin hypothesis, which has now been proved to be false only because of the neurogenic hypothesis. So we're not really sure. Further research into this would be useful. And secondly, are there certain people better suited for one type of treatment or a combination of treatments? And this doesn't even have to be therapy or medication, right? There's other types of treatments that studies have done for like exercise, yoga, meditation, and breathing work, etc. And they've all been shown to be effective methods of treating depression. So what about those non-pharmaceutical interventions? And the second part to this is, I mentioned this earlier, but the participants in this study, they were treated based on their symptoms of depression, right? Major depressive disorder. But we don't know any of the origins or causes of depression for these people. So would it be possible to treat depression based on the origins of depression rather than just the causes? Like, for example, for those who experienced hippocampal atrophy as they got depression, would medication work particularly well for them? And on the flip side, for those who didn't experience hippocampal atrophy while getting depression, would non-pharmaceutical interventions like therapy or exercise or yoga work particularly well for them? Yes?
I'm wondering, does the neurogenesis hypothesis have an explanation for why the hippocampus is particularly affected by the inability to create?
Oh, yes. Okay, so the question was, does the neurogenic hypothesis have a reason as to why the hippocampus is affected by the creation of new neurons? So the reason for this is because the hippocampus is one of two brain regions that are known to create new neurons in the brain. Previously, many, many years ago, people thought that you were born with the number of neurons, and then you stayed, you had a certain number of neurons that you were born with, and for your entire life you would stay with that number of neurons. But now we know it's not true because the hippocampus is one of the brain regions that creates new neurons. So yeah, that's why the neurogenic hypothesis is correlated with the hippocampus. Yes?
So how did we find that the hippocampus creates neurons in comparison to how we believe we didn't create any initially?
The question was, how do we know if the hippocampus creates new neurons, whereas before we didn't? This paper doesn't talk about it, but other studies do. Yes?
So I'm curious about the process of neurogenesis.